Dear Professor Tannenberg, dear Professor Borger, thank you for giving me the opportunity to present our data here at this meeting. Yes, the European ROS Registry, well actually it's a Dutch-German ROS Registry, and we have the Erasmus Medical Center from Rotterdam and another 11 German centers contributing to the registry. And now we're looking over 1,600 patients, mostly male patients, and 280 children within those 1,600. And mean age is almost 40. We have a completeness of follow-up, a clinical completeness of follow-up of 96% with a maximum follow-up of 20 years. Patient years over 10,000 now. And if you look at the post-op echoes, there we have a follow-up of, for this presentation, 80%. We look at almost 6,000 echoes, and 44% of these are performed after 5 years, and 11% of these still after 10 years. So if you look at homograft regurgitation at last follow-up, most of the patients have hardly any regurgitation. That is 60% with trace, and only a few patients with a 1 of 4 regurgitation. And then we try to look at the development of the aortic regurgitation over time, and we here use the model which has been introduced by Professor Tannenberg in 2005 for valvular evaluation. And this model gives you the intercept, that is at the day of surgery, the regurgitation or the stenosis at the day of surgery, and the slope, that is the increase of regurgitation per year. And this is for the adult study group, 1,400 patients, and at the beginning of surgery there's a regurgitation grade of 0.4, and the annual increase is really low, so after 10 years you have an increase of 0.3 grade for the whole group for the adult patients. This also is the same pattern for the children. If you look at the influence of patient age and with respect to homograft regurgitation, you can see that there's a significant difference between older and younger patients. The younger patients have a higher degree of regurgitation at the day of surgery, but for all those groups there's no difference in the increase of regurgitation over time. Now if you look at the children, again, significant differences at the time of surgery, but actually no statistical difference over the years. Looking at donor age, the homograft age, and here we can see, which has been pointed out before, that at the time of surgery, the younger patients have a higher grade of AR, whereas the older ones don't, but the increase per year is really high for the older patients, and after 10 years they tend to meet at the same point up here. For the children, again, significant difference at time of surgery, but looking at the development over the years, there's no difference for these young patients. By the way, children in this ROS registry were defined as children till the age of 16. Now what happens if you implant a too big or too small homograft, and we use the Z value, that is 1 standard deviation above the standard deviation for that special patient. And if you, in the adult population, implant a too big homograft, you can see that it's slightly higher at the time of surgery, but there's no difference with increase over the time. And this is very much different for the young population. No difference at time of surgery, but the annual increase is really important. So if you try to implant a large homograft by maybe getting rid of stenosis in the long run, you also get a higher degree of regurgitation over the time. So this is slightly different than in the adult population. And finally, another very important issue is homograft stenosis, the pressure gradient development, because we know that is the main issue of problems within this group. And here at last follow-up for all our 1,600 patients, rather good results, I must say, for almost 50% less than 10 millimeter mercury. A few patients are at risk for reoperation. But then we have a slightly high number of unknown cases in this echo follow-up study, which is a drawback. And as we were using this model, we were able to see that most of the things happen within the first 2 years after surgery. So within the first 2 years, there's a more stronger development of aortic stenosis, but after 2 years, this kind of flattens out. So we focused with our evaluation on the first 2 years. For the adult population, you can see at time of surgery, 5 millimeter mercury over the homograft with an increase of 2 millimeter per year. So that's 4 millimeter mercury after 2 years. If you look at the children, there's even more going on. And you there have an increase of 8 millimeters for the first 2 years, but then this also flattens out. What happens if you look at the patient age? Well, the younger patients have a slightly higher grade of stenosis at the time of surgery, but there's no difference among the different age groups for development of stenosis. For the children, a little bit different, no significant difference at the time of surgery, no difference for the development over time. Again, looking at the too big or too small homograft and looking at homograft gradient development, if you implant a too small homograft in the adult population, you have a higher grade of stenosis and you also have a steeper increase of development in the first 2 years. So undersizing is not favorable in this patient group. Now looking at children, no difference with respect to gradient development at time of surgery and over the years. Now looking at reoperation for the whole patient group, now we have good data for 12 years, good results for the adult population, and I think also good results for the children population. But here at the end, this is mostly due to heavy stenosis, and if you look at the numbers, you can see that after 5 years for the adult population, 99% freedom from reoperation and 90% freedom from reoperation for the children. At 10 years, 96 for the adult population, but 85 for the children population. That's due to gradient development. Now, I'd like to conclude for the two different patient groups, and you have to look out when you have certain factors that you can influence, and you have certain factors that you can't influence. And if you look at the stenosis, you have to be aware that the young male patient with an undersized homograft and a surgical adjustment, I haven't shown that slide, and might be at risk for higher development of homograft stenosis. And if you look at regurgitation, it's the young female patient with an oversized homograft and a very short homograft and also homograft surgical adjustment who might be at risk for a higher grade of regurgitation. If you look at the children, for the stenosis we can say that there is a substantial increase of stenosis over time. Using larger homografts does not have any influence on stenosis development. And if you use homograft from older donors, and this is quite astonishing, you seem to have a lower grade of stenosis over the time. If you look at regurgitation, this is not substantial over time. It is influenced by a larger homograft. The larger the homograft, the higher and the faster the development of regurgitation. And it is lower in homografts from older donors. And these are the members of our registry, and without their contribution, all this would not have been possible. Thank you.
Torsten, this fantastic presentation with very impressive data analysis. I have a quick question for you. You say that we shouldn't put in a homograft that's too big and we shouldn't put one in that's too small. So the obvious question is, how exactly do we size a homograft both for aortic valve disease and prosthetic aortic valve disease? So native and prosthetic aortic valve disease.
Well, we use the Hager-Stylighter and try to get a real exact size for the homograft size.
But then you have a 30-minute lag between then and when your homograft is going to be thawed out then. So in advance then, do you have any tips?
Well, we try to do it with the MRT, but that's not ready to be published yet. But that seems to be a way to look at it properly. Echo doesn't seem to be very helpful for the homograft. It's hard to measure.
And have you looked at blood group analysis?
Well, we have.
Blood group type?
We have very inconsistent data in the registry with the blood group, and blood group doesn't seem to have as much as an influence as we thought it does.
Yeah, it's interesting because I really don't understand the immune hypothesis. I'm I'm a surgeon, so I think in simple terms, but when patients reject their hearts after heart transplantation, they don't get calcified coronary arteries, they get that soft, cheesy atherosclerosis, and I don't understand why we think then that calcification, which we see in homografts, is an immune disorder. But I don't know, do you have a quick answer to that, why we should?
No, actually no.
A quick question? No.
Actually, this is a very important issue, and there was a lot of studies and discussions on it. To make a shortcut, the kids below 5 years, they have very severe and fast calcification, and the rest of the people have no such a fast degeneration of the homograft. And I think the most important factors are not the mismatching of the blood group, but the factors coming from the kids.
But when you look at the aortic valve of a kid's heart that's been transplanted, that you're doing a retransplant on, the aortic valve is almost normal. It's not severely calcified, which makes me think this is a different mechanism. But that's a different topic. Do we have any other quick questions? So our last speaker is going to be, thanks very much, Torsten.